Welcome to the Global Health Equity Miniseries. I'm your host, Harvey Kennedy Pitt. Join us as we look at 8 public health principles that can help health systems build capacity through adaptation. Well, good afternoon. We happen to be in a similar time zone. Robyn Stephenson, Dr. Stephenson, really glad to be having this conversation with you on a nice sunny afternoon, and it's a pleasure to have you in this space. So we'd like to begin this kind of conversation on global health equity with a bit of an intro. So tell us a bit about yourself.
Hi. So thank you so much for having me. It is a lovely sunny day and I'm super grateful. They're so rare, as we know. So I'm Robyn Stephenson. I am a public health specialist, strategist, and director of a nonprofit company. My background is actually in healthcare, so in medicine. I graduated with my MBBS many years ago. And I was practicing in primary care in Jamaica for quite a few years and then made the shift to public health when I did my master's in public health, actually here in London during the pandemic, which was a very different experience. And after I completed my master's in public health, essentially, I just transitioned into doing more public health roles. So I started with some program management. I for a couple of years was coordinating our local area HIV and STI program, which was a lot more clinically focused, but also had a lot of resource distribution, dealing with people's stakeholders. I loved it. And then I've transitioned recently into working in local government, public health here in the UK. I've always been attached to local government or local authorities. I do not have grand aspirations to sit in some national body. I think it's too far away from getting my hands dirty. And so yeah, I'm enjoying kind of the space where I'm in now, which is a little bit of interacting and engaging with the community and having like a lot of that thinking strategic time to kind of drive public health changes and improvements. Yeah, so that's I think a little bit about me.
Amazing. Okay, so obviously you've worked within the clinical environment. You've also worked within local government environment. I know that sort of ministries of health is something that we see a lot more in sort of the Caribbean or across many countries in Africa. When we talk about sort of London or England, this looks a little bit different in terms of who you engage with, how and why. But I guess my question to you is, who would you say you're mainly engaging with now? You mentioned clinical spaces, communities, but I guess it's a multi-level stakeholder environment.
Yeah, so you're absolutely right in that it's a multi-level stakeholder environment. So with local authority public health, I don't know how much your viewers know about how like public health sits here in the UK, but just a brief overview from my limited experience.
Yes, okay.
But public health moved from the NHS, which is, the main clinical body, into local authorities back in about 2012, 2013. And the reason for that is because a lot of public health work was addressing more social determinants of health and health inequalities. And it was felt that by moving them closer to local authorities, which were responsible for providing these social determinants, things like the environment that we live and work in, green spaces, air quality, things like that, you'd get more impact, more bang for your buck with public health work. And so, where I sit now in a local authority, I have engagements with the NHS still, with the other departments in the council that I work in, with the local voluntary community and social enterprise sector, so the VCSE sector as well, and occasionally with community enterprises, so like private organizations like football clubs that also have an interest in like social development, and so academic bodies as well. And so it's kind of it's a crowded space, but there's a lot of good work happening, and a big part of like working with so many stakeholders, as you know, is just kind of trying to keep on track of everything and keep an eye on everything to make sure things are progressing, that we're not duplicating any work, and that everybody's kind of aligned to the same mission, to the same goal. Most of my work these days kind of centers around long-term conditions and healthy aging. So I do a lot of work with diabetes prevention, with heart health, and cancer screening programs as well, in my day job. And then on the flip side now, I've got this NGO or this nonprofit that I'm a director for back in Jamaica still. And we do a lot of work around community and community spaces. And that's more about expanding healthcare access for marginalised women, essentially. The name of our NGO is Margin to Centre. Yeah.
Amazing. Okay, and you're kind of gently talking about margin to centre and kind of mostly talking about local authority spaces and the NHS. But of course, we know that it is all interlinked, even when we cross, country borders and sort of talk in a more international context. Now, obviously, we wanted to speak really to social justice through this conversation today, and I think that this is a conversation that, in a very light touch way, we might kind of hear within really formalized public health systems, but really it's a conversation that continues to remain on the margins. It's kind of on the fringes of core, I guess, public health conversations. Now, in the global health space, we'll talk about global public health. Even social justice is absolutely at the core of why we do it, and naturally we see why that's important with all that's happening in the world at the moment, and the need for a social justice mindset. And I'd just be more curious about, and you can talk through margin to center, or you can talk in your wider work, what problem you would say that you're trying to solve through your work. You mentioned accessibility, but what else?
Yeah, so I think if I was to distill it down, and I spent a lot of time like trying to brainstorm to think about, how to distill down all the different things that I do, because on any given day, I feel like I'm trying to solve all the problems in the world all at the same time. And so when I distilled it down, it came back to kind of the margin to center ethos. So for those of you who may not be familiar with feminist theory, Bell Hooks, prominent Black feminist writer, wrote a book called Feminist Theory from Margin to Center, and it's kind of where we borrowed the name. And so that theory, that concept is about bringing people who live and exist, who live and work at the margins of our society, those people who we tend to forget about, or the ones who are easy to ignore. If we focus and center and concentrate all our efforts and all our activities on improving the quality of their lives, everybody benefits. And that's essentially one of the core roots I find to social justice work. So the problem essentially that I'm trying to solve is a problem of decentering. I like to, there's a lot of isms and schisms that we can get into around that. Anti-imperialism is one way of looking at it as well. But the crux of my work and the work that I do as a public health specialist is really about decentering bodies and systems that have traditionally held power and use that power to oppress or problematize other bodies and systems. So if you work in healthcare, you will know that the ideal patient, so the default patient that we use for everything, is a 70-kilogram white male body. And so one of the core things of margin to center, by centering women's bodies, by centering Black women's bodies, by centering queer women's bodies, disabled women's bodies, one of the things we're trying to do is shift a narrative around opening up that concept of who is the ideal patient in medicine and who are the communities that we need to be putting at the center of our efforts, but also what do those communities need? And that's going to look differently from what a 70-kilogram white man needs. And so that's a big part of the work that we're trying to do. Tied up in that, and some people might push back, is this concept of male marginalization. So you might hear men talk about, oh, but men are being pushed to the margins, we're being pushed out, there's women in all of these jobs in academia and all of these positions. And I will say that, reflecting on that, it's like, one, if you feel that there is that problem and that is your lived experience, by all means, advocate for it, go for it, make the change you want to see in the world. But also on the other hand, like when you consider the historical weight of women's oppression, gender oppression, that kind of thing, it's very clear that what we're seeing now is a slight shift in that power imbalance that starts to make things a little bit more fair. But also at the same time, we still aware that we have those glass ceilings and those sticky floors. So while you might see a preponderance of one gender in one area, it doesn't mean that their hands are still on the levers of power. It doesn't mean that they still have the agency to be able to make decisions about their lives. And so bringing it back to the question, my work is really all about always trying to challenge and disrupt who we hold in our minds as the default person or the default thing that we should be working towards. And the counterbalance of that is the default problem. Because if you've got an ideal on one hand, that means everybody else is non-ideal and problematized. And so I'm always trying to challenge those two concepts.
Absolutely, and a lot of the basis for my much earlier work was around Dorothy Roberts' kind of work in thinking about, racialized medicine and why race-based medical practice is so dangerous. When we talk about lung capacity, when we talk about bone capacity, we talk about BMIs, we talk about the implications of how that impacts people. When we're talking about in the social justice context, I believe in reflecting on what you're saying, this is exactly what you're referring to, and it's the harm that can come not just to, a portion of a population, but harm that comes to everyone as a result of not thinking more intersectionally, thinking through the right lenses, asking the right questions, exploring difference. And we know what we know about BMI through more recent exploration of this, certainly when it comes to Black maternal health, and that's continuing to be a really big conversation both here and abroad, trying to figure out why the outcomes are the way that they are. And I would encourage you to look into those who are listening to really look into the latest work on Black maternal health through organizations like Five Times More, or even through wider NHS data availability. So I'll not steal the show from you, Robyn, but you've actually answered a couple of my other questions around what sparked your interest in social justice as a principle out of all the other principles that we sort of champion through our work, but also how we can make that meaningful. And I think you've also started to answer that as well. But I would like to know a bit more about the meaningful bit. I think other people listening will be saying, well, I'm doing social justice at work. I work for such and such local authority, or I work in local government, or I even work in a private sector organization, or I'm a consultant, and I think what I'm doing is really meaningful. But we know there's always room for growth. So is there anything that you'd like to say about how we can all make what we appear or think to be championing really and truly meaningful?
Yeah, I love that question. And I could go on about this all day because I really do feel like it's a praxis. So I don't know, again, if you're familiar with Frere's concept of practice, so that action, reflection, action cycle of doing and then thinking about and learning and reflecting on what you've done and how you can do it better. And so that's kind of the approach that I take to social justice work. In terms of how we can make it more meaningful, I am still trying to figure that out.
Yeah, yeah.
It's an ongoing process. And ever since I first started on this journey, leaving the hospital to work in primary care, constantly asking why, how can we make the changes that we want to see? How can we keep people healthier? And the questions have evolved as well. So it became, how can we get people to stay healthy? How can we give them the tools to stay healthy? And then it became, how can we create an environment where people are able to make healthy choices and choose to make healthy choices? So for me, it starts with listening. It really, really starts with deep listening. Some might call it active listening, but really and truly listening to the communities and the people that we are trying to provide services to, deliver services to, or support, whatever verb is your jam. At the end of the day, we are here to, as public health specialists and as people who work in health and care, we are here to ultimately serve these communities. I remember a lecturer I had one time said, as a doctor, as a physician, as a healthcare worker, it is our privilege to facilitate people returning to good health. And that really stuck with me, and I've taken it with me ever since. So it's listening, but it's also action. And I find I get very impatient very quickly when we have a lot of data and a lot of reports, and we've done the listening, and we just keep talking about the things that we've heard, and there's no action. And so it's also about knowing when to make the call, to make the change. I think sometimes I found working in this country, which is a little bit more regulated, a little bit more structured, versus in Jamaica or the global south, where like innovation is a little bit easier to tap into. I found that there's a hesitation or a fear to do the wrong, about doing the wrong thing or making the wrong move. And so you don't act when you need to act, not recognizing that inaction is
Yeah.
also an action. And so
Yes.
without acting, you're maintaining the status quo, and that's
Hmm.
also doing harm, if do no harm is your ethos, you know?
Yes.
And so action, we don't have to wait on like all the evidence in the world before we act. Sometimes we're doing some parachute RCTs, and you
Absolutely.
just need to, you just need to do the thing that you know is right. If you need justification, the evidence is there. One thing I love about this environment, meaning like this country, is how much research has been done over the years. Like there's decades and decades of evidence being built up, and it's just there at your fingertips. We don't need to say that we're waiting to see if something works before we do it, because based on the history of this country, chances are it was already done and somebody's
Yeah.
doing it somewhere already. So it's
Yes.
just about tapping into that and not reinventing the wheel. So it's listening, deep listening, it's action. It's also putting the power back into the hands of the people. So there's, that typical public health thing. If you work, this typical public health thing of like, we've got a program, we've got a project, we've got a thing to deliver. So we're just gonna like swoop in, we're gonna drop that for the 3 months, the 6 months, the 1 year, whatever it is, and then it's like, bye.
Yes. Yeah. Yeah.
That's it, we're done.
Mhm.
But what I find makes social justice work more meaningful, especially from a public health perspective, is when you spend the time to understand and listen to what people want, what people need, what their resources are, and you put yourself in the position of facilitator, not doer. So you
Yes.
stop thinking about yourself as the center of the project, or it's your project to deliver. I know, like, you are the responsible person who, if it doesn't go right, somebody's going to come back to you. But your role really, and the way I see my role really, is to offer up my skills, my knowledge, and my experience for people and communities to be able to use in the way that they know best
Mhm.
they will need to achieve the health outcomes that we're trying to get them to achieve. On a global level, decolonize is the
Yeah.
way to make it more meaningful. It's always got to come back to that. I talk about my work as decentering imperial structures. On a global level, always thinking about shifting away from that kind of Eurocentric, global North centric model or way of doing things, I find. A lot of the time in the advocacy space, and I've dabbled in there a few times over the years, a lot of the time in the advocacy space, you find that you tend to default to what the grant funders want you to do and the
Absolutely.
way they think, because that's how you have to write the grant application. So you start to fall into the trap of thinking that way. And I
Mhm.
think there's a way, and Caribbean feminist and Daya talks about this, is a way that we move away from our grassroots roots. And we lose that connection to community that made our work so meaningful in the first place. And I think if we can constantly check ourselves and constantly ask ourselves and come back to that thing of, who am I centering right now? Whose voices am I centering right now? Whose way of being and way of life am I centering right now? We can start to make those meaningful shifts that we talk about wanting to make, but we sometimes completely miss the mark. Yeah.
I mean, there's so much in there. I almost feel like as you're speaking on this video, we need to make sure to put some definitions there, like just have them popping up, things like Eurocentric, thinking about decolonization, what does that actually mean, and sort of ensure that those are really clear to the listener, because they're words that we probably hear all the time, but I'm not sure how much time we take to chew on them, to try to chew the cud a bit and kind of digest it and ensure
Mm.
that it sits and it becomes a part of who we are. And that's a very digestive system way to explain. But I think that is what it really becomes. That's what learning, you talk about learning in action. I was recently reminded that learning isn't embedded until action is taken. We can't demonstrate we've learned it until we can actually take action with that. We can't just go around saying, well, I've learned it. Well, how do we know? And so, there is that deeper work, and there is a tiptoeing, I think, around phraseology and words and semantics of Eurocentrism and decolonization and decoloniality, because people feel like that is fluffy. They feel like it's fluffy talk. It's woke culture, and this is where we are at the moment. It's currently, as we're recording this, it's currently just the end of March. By the time people see this, I'm sure that will be beyond the 90-day freeze that has come out as part of the executive orders, and we'll know what the actual damage has been. But I do believe that a commitment to engaging with the uncomfortable is certainly something that we all should be considering and need to be considering and have evidence of how we're putting that into action. I think, speaking of action, people might be wondering, whoa, this has been a lot of information. It's been very exciting. It's very informative. But what can I do? And so this is the point where I normally ask my guests, what is your call to action, to those listening?
Yeah. Yeah. I just let me take a second to just circle
Yeah.
back to something you said, because you talked about words, and I feel like that's so important because, like, my second love was language. I was a literature student, loved it, almost did journalism instead of medicine as a career. And when we talk about words, it's so critical. And I appreciate you saying you're going to put the definitions in the video, because it's so important that when we say something, that the other person understands what we mean. So when we say the color red, we're thinking about the same color red, that kind of thing. And one of the words I found out, the way we use words in public health can transmit a lot of what we maybe are not intending to say. And one of the bugbears that's been just like nattering in my ear for the past couple of months is the way we talk about race and risk in health. And you've probably heard this. I was at the Black Healthcare Summit earlier this week, and Professor Margaret Ikpo, I think is her name, said this thing that stuck with me. And she said, there are no high risk people, there are no high risk populations, there are only high risk systems. And that
Mm.
really stuck with me, because I've been starting to question the way that we talk about who's at risk for this condition, or the Black maternal health risk. And it was bothering me, in part because on a community health talk, a person who was not of the global majority, so she was white, she asked, why are these populations more at risk of I think it was hypertension was the topic. And she was, is it because they live in hotter countries, hotter climates? And I had to kind of pause and like reckon with myself about what it was about the conversation that conveyed this idea that the risk was intrinsic to the body that
Yes.
carried it. So the problem of the risk rested on the body that we were labeling as high risk. And ever since then, like the way I've thought about communicating risk has shifted. And so I've been very conscious about communicating the risk that we associate with racialized bodies, so people from the global minority, Black and brown bodies, is actually a risk of racism and not race. So that's
Oh, yeah,
that's that's
absolutely.
where the risk lies. And I know this will not be news to you. It probably won't be news to other people, but I think there's a way that we recognize these truths in public health in particular, and we don't necessarily act on them. We talk about them. We do talk about them in specific and prescribed spaces. We talk
Oh,
about them in our racism subgroups and in our Black health summits and our South Asian health summits. We will talk about them. But when we're away from those spaces in the wider world doing the work, we somehow forget that these
mhm.
concepts and these problems and these challenges need to be done on a daily basis. It's not just the once a year conference or the every 3 months focus group. So sorry, I just wanted to have a mini soapbox moment about the use of language. Yeah.
Yeah, no, absolutely, and that is what I'm hearing is we need to identify the shared meaning, and have an agreed meaning. So you've said that, and I've heard you say that, and I'm saying that, and you're hearing me use the same phrase. Do we mean the same thing? And if we
Yeah.
don't mean the same thing, what do you mean and what do I mean?
Yeah.
And then how do we move forward from that? So that shared meaning, which is a very qualitative, interpretivist way of thinking, how do we identify the shared meaning between, say, a researcher and a study participant or a lived experience participant? You can't move forward and say, well, this is what I found in all of my research unless we agreed on a shared meaning of what's being said. And so certainly that reflection is essential and really critically valuable to this conversation.
Yeah.
So I'd guide you back to your call to action
Yes.
and what we can actually do to take this conversation forward as practitioners all over the world, with different contexts and different perspectives and different political environments. What works in the US will not work in the UK. What works in the UK will not work in Zambia. What works in Zambia will not work in Turkey. We know that even Tunisia, the stories are emerging of how policy is shaping possibility. What are those call to actions?
Yeah, so my call to action, and it's a call to action to myself as well as other people, is to get curious and to stay curious.
Okay.
And what that means is to constantly be asking more questions. For people in power, that looks like asking who's missing from these conversations, who's not at the table, who's not in the room. Are we talking about somebody or groups of people who are not here? So get curious and stay curious. Constantly also check ourselves and check our positionality. This is a nice qual word there throwing out.
Insert definition there. Yeah,
Insert definition.
yeah.
But it was a really useful concept I learned about when I was doing my master's. And it's just, this idea of recognizing where you stand in relation to other people and being that level of self-awareness is really key to the work. So get curious about where you stand as well. In global movements, get curious about who's being left behind, because
Yeah.
sometimes, we do the work and we advance the cause for like a fraction of the people, but
Mhm.
we don't look in the rearview mirror. We don't check back to see, who is this movement maybe not bringing with us. And that
Mhm.
goes back to the concept of centering, because if you center the most disadvantaged, if you center the most marginalized, you bring everybody with you along the way, because you're starting from like the key point. You're starting from that point of you're not going to leave anybody behind. And are you perpetuating the status quo? So
Mm.
get curious, and in that curiosity, you're also gonna have to get comfortable with your own discomfort, because things might come up about yourself, about the practices, about the environments that you're engaging in. And even when you start to ask these questions, people might not like these questions that you're asking. They will push back. They will want to preserve the status quo, and that's going to be uncomfortable. That conflict, that constructive challenge is a word I learned recently
All
working
right.
in this area. Is so critical to getting like meaningful outcomes. So get curious, stay curious, and get comfortable with the discomfort that comes up when you are living in that curiosity. So that would
Okay,
be
I'm
my
gonna jump in there though. I'm gonna jump in there and I'm gonna point out that you mentioned white people earlier on. Now, I'm asking a question knowing what I think about the answer already, but I'd love to hear your position on this. And that is there a status quo? Is there a positionality? Is there a power dynamic for people who present as black and brown as well in their practice, would you say?
absolutely,
I don't want to miss
absolutely.
that. I just don't want to miss that.
Yeah, no, absolutely. It's not just about racialized bodies refers to everybody, right? Like we're all existing in this race soup. So black people, brown people have a race, white people have a race, and we all have positionality, and we all need to be able to check our privileges, check our biases, because just like you said, what how life is in the UK is not how life is in the US, is not how life is in Zambia, is not how life is in Turkey. And all of us will have had differing experiences and differing exposures that create the lens through which we see the world. And we really are, especially as like activists from the global majority, we have a way of thinking that because we also inhabit a variation of the body, that we're advocating for and pushing for, that when we've achieved a certain thing, that means everybody's come with us. And no, we really need to start checking that and making sure that I am so sorry, my cat is in the background. I hope you can't
Ah,
hear her.
that's okay.
Yeah. But we need to start checking our positionality around where do we sit in relation to the bodies and the communities that we are trying to take with us in this movement. Because by the default of being in a position to lead a movement, to action a movement, to contribute to something, to start an organization, by that default, you've already separated yourself a little bit from the community that
Absolutely.
you're serving. And you constantly need to be checking what is that relationship, and going back and comparing notes, and building that shared meaning like you talked about. Yeah,
Mhm. Yeah,
absolutely.
this is exactly why I wanted to ask the question because certainly in the global health space, got to be careful who we call out and who we quote here because we wear multiple hats. But we are reminded that as we are parachuted down into, you mentioned parachute earlier on, as we are parachuted down for a very set amount of time, that you go in and maybe you mix your walk up a little bit and you try to say, oh yes, I'm just rough and regular like everyone else. I'm just everything. But you've parachuted down. You've parachuted down from a position of privilege. You've come in with resource and you've been resourced to be there. That is the privilege separation. That gap is massive, whilst also looking exactly like the populations or very similar to the populations that you're trying to serve. And so we as Black practitioners and Black academics and all the things as well, Black and brown people, we've got to think about that as much as our white colleagues and counterparts, because it's a collective movement. We've all got to sort of be working together. And as has always been said, no man is an island. And so that's kind of an example of that yet again. So I would hate for this conversation to be as good as it's been, and for people to say, "Oh right, well Robyn came on and it was a great conversation," and off the conversation goes, "How can we get in contact with you and stay in touch and follow the work that you're doing as you move through your journey as well?"
Yeah, fantastic question. I have spent all week preparing things.
Oh, right. Okay.
So people can check me out on LinkedIn. Obligatory LinkedIn plug. My name Robyn Stephenson. It's there. The one that says Public Health and NGO Director. I'll be updating that in the coming weeks. I've also transitioned to Blue Sky as a social platform. Kind of moving away from Twitter. I'm still on Twitter, but I don't engage or interact as much there. And on Blue Sky, my at is at Robyn as, so Robyn AS. I am on Instagram, but on Instagram, who I'd love for you to follow is my NGO Margin to Center.
Nice.
Please, and that's margin to the number two and center the British spelling, the colonial spelling,
Okay.
CENTRE. Yeah.
Okay. And it
It's
will
important because there's another margin to center with the American spelling. Totally
uh,
not this.
oh, right. Okay, so that's important to recognize, particularly when we tag you up here as well. We don't want to tag the wrong person.
Yeah.
Okay, so that's useful to know.
Yeah.
Okay, well, I think that's is there anything else you wanted to add to that list?
No, that's it. Yeah.
Okay, good, fantastic. Well, I think this has been an absolutely robust conversation, a much needed conversation. Some similar conversations within this particular series, but of course, completely different with a focus more on, racialized bodies and really thinking about women's health and thinking about positionality and Eurocentrism, which is really exciting to bring into this conversation and this series as well. It's been a pleasure having you here today. And I won't steal any more time from you from a nice sunny day, the rare sunny days that you get in London, down in the big smoke. But we look forward to connecting with you again, if not virtually, in person, if not in person, virtually, and following your journey. So thank you so much and have a lovely rest of your day.
Thank you so much, Harvey. It's a pleasure.